As an advanced life support instructor, it is my job to watch people provide emergency care, such as CPR, to patients, and to give feedback on what went well or what can be improved in the future. In this video, we're going to watch the lifeguards of Bondi Beach provide CPR to someone whom they found drowned in the waters. Let's have a look.
Mask! Okay, who's doing? I'm going on. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, get the back, come on, 14, 16, 17, 19, 20. I'm just going to keep going until you get this ready. Just keep going, okay? I'm just going until...
Try and get that, get down in.
So one of the first priorities is to make sure there's a clear airway. From this video, you can see that as they're inserting what we call an airway adjunct into the mouth, you can see there's still seawater coming out. This tells me that the airway might still be partially obstructed and not fully clear. It is times like this when a portable airway suction kit is important, so that you can suction any seawater, foreign material, secretions from the mouth as well as the back of the throat, so as to at least clear the airway. There is no point in trying to force air using the bag valve mask into a patient's lungs if the airway is obstructed, and in some cases it might be more dangerous, as a positive pressure from the bag valve mask could force foreign material into the lungs. A suggestion that I will make to the team is to have a portable suction kit in the emergency bag that they bring to the scene in the future.
Pulses as well. Anybody been called?
Let's get the deep in. Maybe we need someone to come up.
I've watched a few of these videos and I find them very interesting. And I notice whenever they find a drowning victim, they're always frantically trying to find a defib. One thing people don't realize is that when you have a catastrophic cardiorespiratory collapse as a result of a lack of oxygen, like hypoxia, like in the case of drowning, for example, the underlying rhythm is normally a pulseless electrical activity or asystole. In other words, these are rhythms that are non-shockable, and the defib is not going to do anything for you. In any patient that has arrested as a result of hypoxia, the priority should be good quality CPR and of course making sure that you give oxygen. This is very different from patients who have an arrest as a result of a heart attack, for example, where the rhythm is normally a shockable one. But I'll cover more of this in my upcoming videos. In this section here, you can see that they're using a towel to try to wipe as much water and moisture from the chest. This is important as you want to make sure that the pad has got a good contact and is fully adhered to the skin. In hospital, we even have shaving kits on the crash trolley to remove any chest hair from the patient before sticking the pads on. If the pad is not fully adhered to the skin, this can result in insufficient energy transfer from the defibrillator into the patient and will result in an unsuccessful shock. Furthermore, poor contact can sometimes cause an electrical arc to form between the pad as well as the skin, resulting in an electrical burn.
We're happy we've done this a lot of time.
Keep going, Maxie. Okay, two breaths, mate. One. Just slow it down. Let's go. Pads on.
In this case, we have got an anaesthetist who happens to be on the scene who is trying to help. In here, he's asking the person doing chest compressions to slow down. You're meant to do compressions at a rate of 100 to 120 compressions per minute. In this video, the person doing chest compressions is doing it too fast. He's doing it about 3 chest compressions per second. If we do compressions too quickly, the heart will not be able to fill up with blood adequately in between compressions, resulting in not enough blood being circulated around the body during CPR. But I'm nitpicking here because they're doing a grand job. Remember that if you find someone whose heart has stopped, any CPR, whether too fast or too slow, is still better than no CPR. In here, you can see the lifeguard telling the anaesthetist that he has done this many times before and they know what they're doing, even though the anaesthetist is right in this case. When I'm involved in CPR, even when I'm team leading, I always listen to my teammates. And I actively ask them if anyone has any suggestions or if there's anything that I've missed out. And there's multiple times when my juniors have come up with very useful suggestions that I have not thought of, just because I'm under pressure.
It's now 4 minutes since the man was first discovered. No one knows how long he was under the water before then. It's critical that no one touches the man's body while it is shocked.
Get off! I know you can't touch him. Don't touch him. You'll get electrocuted.
When the machine is assessing the rhythm, you shouldn't be touching the patient, as theoretically the machine could detect your electrical activity from your heart rather than the patient's. A shock is only delivered when someone presses the button on the defibrillator. It is a safety mechanism that's inbuilt into the defibrillator. I think that they were overacting just a little bit just to get the patient's friend away from the scene. Before the button's being pressed, it is the responsibility of the team leader as well as the person that's about to press the button to make sure that no one is touching the patient or near the patient.
Then, at least 5 minutes after the man drowned,
Has he got a pulse? I've got a pulse. I have a pulse.
He's back, he's responding.
Let's go.
In this case, you you can see that they are checking for a pulse on the wrist, which is what I classify as a peripheral pulse, and I do not recommend this. I recommend that a central pulse, such as a carotid pulse or femoral pulse, be palpated or felt in these cases. Especially in a post-arrest situation when the heart is just restarting, the pulse might be quite weak and could only be felt in a central pulse, such as the carotids or the femorals, and will not be easily appreciated on the peripheries, such as the wrist or the ankle.
Let's go, let's breathe with him. Breathe with him.
I've got a pulse, I've got a pulse.
Breathe him up then.
I've got a pulse,
I've got a good
Yeah, I know,
pulse.
we're going to breathe him up.
I've got a good pulse. Good work, boys.
He's alright, mate. We got him. We got him, mate.
Keep breathing him.
Now watch this video to learn how to transfer patients safely around hospitals, a skill that I believe is not very well taught in medical school or during medical training. I hope that helps.